All right, well, welcome everyone to the third edition of the National Virtual Leukemia Conference. This is a one-of-a-kind conference to address the unique needs of the blood cancer community and offer the latest information, tools, and resources to help support Canadians touched by leukemia. The Leukemia Lymphoma Society of Canada is proud to introduce today's presentation, Advances in Research and Treatment of Chronic Lymphocytic Leukemia, or CLL. In this session, Dr. Anthea Peters, a hematologist at the Cross Cancer Institute in Edmonton and associate professor at the Department of Oncology at the University of Alberta, will talk about research advances in how we treat CLL, the most common type of leukemia in adults. This type of leukemia can vary from person to person. This is why a one-size-fits-all treatment approach is not optimal. Before we begin, let me introduce myself. My name is Natasha Sani. I'm the Community Service Lead for the BC Yukon region at the Leukemia Lymphoma Society of Canada. I'll be moderating the event today. We invite you to type your questions and comments in the Q&A box of the Zoom webinar. You can find the panel at the bottom there. An LLSC staff member will monitor the questions throughout the presentation, and at the end, I will read some of the questions out loud. Due to the large number of participants and the limited time, we may not be able to answer all the questions. And please note that Dr. Peters cannot answer specific questions about a personal health history or status. Today's presentation will be recorded, and therefore you can rewatch it again on our website. If you wouldn't mind changing the slide for me, please. As we come together from across Canada, we recognize that we are on the lands cared for by many Indigenous nations. We honor the First Nations, Inuit and Métis people whose deep connections to these lands enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, belonging, and health equity guides how we work to support and uplift everyone affected by blood cancers. Next slide, please. Are you looking for specific programs or resources but not sure where to find them? We are here to help. You can connect with the community service lead in your area to receive personalized assistance and get connected to resources in your region. You can reach out to us by calling our toll-free number 1-833-222-4884. Slide, please. We know that having a diagnosis of CLL can be very overwhelming, but know that you are not alone. There is a blood cancer community that is here to support you every step of the way. And as mentioned earlier, you can access one-on-one support to help you navigate your blood cancer experience. Next slide, please. We invite you to visit our website, bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. Next slide, please. On our website, you will find tailored information and resources in multimedia formats to address the variety of needs and preferences, including those that are specific to CLL. This includes fact sheets and booklets like the one you see up here on the screen. Next slide, please. We also have a podcast channel. It's called The Blood Cancer Experience. Here you can find hundreds of podcasts for people touched by blood cancer and caregivers, and many people addressing challenges that people living with CLL face. We speak to experts about current topics such as treatments, diagnosis, and research, and we also hear personal stories from people who are touched by blood cancer. Next slide, please. And finally, some information and resources to watch, like the series of animated videos on CLL. We have Understanding Treatment Options, Side Effects, and Genes. And if you visit bloodcancers.ca, you can read, listen, and watch all of these awesome resources. Next slide, please. In October, we launched the LLSC's Travel to Treatment study. This study is to measure and quantify how traveling for cancer treatment affects individuals and families. We want to gather and present information to decision makers to help them understand the real life impacts of having to travel for treatment to improve support for individuals affected by blood cancer. This study will examine factors contributing to individual experiences like finances, education, housing, and employment to see how travel affects these important life factors. Please fill out the survey using the QR code on the screen. You'll receive a direct link to the survey and a follow-up email 24 hours after this session. We thank you for taking the time to complete and participate in this important survey. Excuse me. Next slide, please. All right, I'd like to now take some time to introduce today's speaker, Dr. Peters. Dr. Peters is a hematologist at the Cross Cancer Institute in Edmonton, an associate professor at the Department of Oncology with the University of Alberta. Thank you for being with us here today, and I will pass it over to you.
Okay, thank you so much, Natasha, for that introduction. So very, very pleased to be giving this talk today on CLL, one of my favorite topics. I am a hematologist in Edmonton at the Cross Cancer. I treat both CLL and all kinds of lymphoma, and as well I do clinics at the Grand Prairie Cancer Center, mostly by telehealth. And there I see CLL, lymphoma, and multiple myeloma. So today I'm going to sort of update you on CLL, but with such a broad audience, I thought I would just start by describing CLL and sort of get everyone on the same page. These are my disclosures. So I have had some involvement with the drug companies that make a lot of the drugs that we're going to talk about today. And I thought I would structure this talk in terms of what I see in the clinic as the most commonly asked questions. So starting off with basics, what is CLL? And I'll talk a little bit about what could have caused a person's CLL. I get a lot of questions about what people can do to help themselves. And of course, the bulk of the talk will be about the treatment of CLL. What are the options? Why is it sometimes not treated? What is watch and wait? And then finally, we'll talk a little bit about the new treatments coming up the pipeline. And then hopefully we'll still have some time for questions at the end. So CLL, it's actually the most common type of leukemia in Western countries. And in Canada, I have a statistic that in 2013, there were about 2,500 Canadians diagnosed with CLL. Because it is a type of leukemia that people live with for many years, the prevalence or the number of people living with CLL is quite high. For whatever reason, we don't understand, the risk of CLL is about 2 times higher for men than women. And seems like there is a sort of concentration or predisposition to CLL more so in Caucasian men and women. So the incidence rate in Caucasian men in the US is about 6.8 per 100,000, whereas Indigenous Americans, people of Asian and Pacific Island descent, it is 1.7 per 100,000. Now, the median age is about 70 to 72 at diagnosis, but in my clinic, I've certainly had people diagnosed younger than that. I believe my youngest was about 32 or 33. So in order to understand a bit about the kind of question of what is CLL, we have to talk about the lymphoid system in the body. So I've pictured here in the middle lymphocytes, which are the cells of the immune system. They can be B or T lymphocytes. And these cells travel all through the body, through the blood system and the lymph system. So they travel through the blood, they travel through the bone marrow, which is actually where they arose from, and where all blood cells are made. It also travels through the spleen and through the lymph nodes, as well as basically everywhere else in the body. The bone marrow I wanted to just highlight because, a lot of what we do see in the clinic sort of comes from the concept of what's going on in the bone marrow. As I mentioned, these are where blood cells are made, including stem cells and including lymphocytes. The main cell types are red blood cells, which carry oxygen through the body, white blood cells, which are part of the immune system, and platelets, which help form blood clots. So when a lymphoma, or in this case, a lymphoid leukemia, is present in a person's body, what actually happens? So these lymphocytes become cancerous lymphocytes or abnormal lymphocytes, and they start to divide uncontrollably, and you see a rise in the lymphocyte blood count. But in addition, you also see effects on the bone marrow. In that we do see, I'm just going to flip to the next slide for 1 second. So we do see, instead of a normal bone marrow with a normal array of different types of blood cells, suddenly there's more of a heavy concentration of the abnormal lymphocytes in the bone marrow, and they just crowd out the normal cells such that red blood cells become low in the blood. They're just not able to be made in proper number. Platelets, same thing with platelets. So this sort of gives you an idea of why when we look at your blood counts in the clinic, we may be worried about red blood cells and platelets, in addition to the high lymphocyte count. So in addition to blood and bone marrow, we also sometimes see enlarged spleen. We also often see enlarged lymph nodes. And we can see effects on other areas outside of lymph nodes, such as collections of fluid in the chest, and so on. This is what CLL cells actually look like under the microscope. So in particular, the ones in this panel A is a typical looking CLL cell. So they just sort of have a nice round shape. They're a little bit bigger than a blood cell. And then this darker part in the middle is the nucleus. When they sort of break open on the slide, they become, as you see here, what we call smudge cells. That just means that they broke apart on this slide. And then sometimes in CLL patients, we see that they have a certain number of these pro-lymphocytes, and they're just slightly less mature lymphocytes. They just look a little bit bigger, and the nucleus is a bit bigger. And the nucleolus, that little dot in the middle, is something that we can actually visualize. Now I say we, but truthfully, at least in my location, we don't actually get to see these beautiful cells. But I just thought maybe some of you would like to actually see what they look like under the microscope. So I just wanted to tell you not to get too into this diagram. This is very detailed, but what I wanted to just introduce is the concept that there is something called IGHV mutation status that your doctor might talk about. This is in regards to the maturity of your CLL cells. So as a general concept in oncology, typically the less mature the cancer cell, the worse it tends to behave. And that is true in terms of CLL. So I'm not going to spend too much time on this, but what you're seeing in the diagram here at the top is what we call a germinal center. And this is where B cells actually mature. So they sort of flow through this germinal center and undergo a process called somatic hypermutation. So not to get into the weeds here, but basically when we have what we call unmutated CLL, that's the subset of CLLs that have not fully gone through this somatic hypermutation process. So they are less mature. So that's pictured here with these squares in red, and the arrows are down, meaning that their prognosis tends to be less good. Whereas the more mature have already gone through the somatic hypermutation process, and they are considered IGHV mutated. And generally speaking, their prognosis tends to be better. So that's just really broadly introducing that concept. Then we also have one other type of high risk CLL, which has to do with this gene called TP53. And it's a gene that's well known in the oncology community because in many, I would say all cancer types, it has proven to be true that if you have a P53 mutation, that your response to treatment and overall prognosis tends to be less good. Now, I don't want to scare you too much. This publication is from 2009, so really quite a bit before we had our novel agents that I'm going to talk a lot about soon. But the way that this high risk group of patients that have this mutation were initially identified was in the chemo era. Because in that era, we saw a stark difference between the survival of patients that had a mutation in TP53 and who did not. And that gap is really narrowing significantly now. This diagram on the right, I just wanted to show a diagram of the actual 17th chromosome pictured here. And what's referred to as P is actually the short arm of that chromosome, so this top arm. And then there's various tests to find mutations. The one we often use is FISH to find areas of deletion there. Sometimes we use something called NGS to find an actual tiny mutation. So not to get too focused on that, but this is what we are referring to with TP53 deletion or mutation. So that sort of hopefully answers what is CLL. Next, what caused my CLL? So this is a bit more where we get a lot of I don't know answers, unfortunately. What we do know is that there's some genetic factors, so that interestingly, if you have a first degree relative with CLL, your chances of developing CLL yourself are 8.5-fold higher. So we do have this knowledge that there is a higher propensity within families. And there are some certain sort of genetic changes that have been associated with this familial CLL, but there's no one gene that we know of. As well, they've identified some environmental factors, things like Agent Orange and possibly insecticides. But there's no evidence for things like radiation or virus infections to have increased this risk. And also there's no evidence that lifestyle factors influence CLL risk, which I think is really important because we're learning a lot about, the effects of alcohol and smoking and obesity in terms of development of some solid tumors. But in fact, that is not the case in CLL. And then, as I mentioned, I get a lot of questions about what what I can do for my CLL, particularly we haven't talked yet about watch and wait, but I find particularly people that are on that watch and wait stage. And I thought this was interesting. I came across a new study dated this year that actually postulated that perhaps vitamin D may have a role in delaying the need for treatment in CLL patients. So I'm going to just flip the slide for a second to show you. This is um, an abstract from this article that was just published, and I'm thinking it was actually based in Israel. They had 3,500 patients, and about 931 had been taking some sort of form of vitamin D, and the rest had not. And they kind of arbitrarily said they had to be on vitamin D for at least 6 months. And then they followed these patients, and they actually found that the patients that were taking vitamin D were had a longer time to needing their first treatment, which is really quite fascinating. So it's not a randomized controlled trial, and I think we need to follow it up with that type of study. But I think this is a no lose type of situation. If you are a patient with CLL, you know, it's certainly not harmful to get yourself on vitamin D and perhaps yield this benefit of vitamin D that we had not appreciated before. That same study did look at patients taking vitamin C and in fact did not find the same effect. And so that doesn't seem to be important. There is a kind of immune deficiency that patients with CLL have, and it's not only the B cell part of the immune system, like antibodies, but also the T cells. And actually, the T cells we're learning more and more are involved in screening for cancer cells in the body. And if they find cancer cells in the body, they can actually, eliminate them at an early stage. So unfortunately, patients that have CLL don't have a strong ability to do that. So we do find a higher rate of other types of cancer in these patients. And so we always recommend that patients with CLL do have a family doctor if they can find one, and undergo cancer screening as a priority. Nothing over the top, like it's not recommended that you go out and get a body scan or anything like that, but just anything that's recommended at your age and stage of life and gender. And then immune system defects are well known, and so we do recommend getting your immunizations. I think I had, oh yes, I just wanted to mention about COVID-19. We're still seeing a lot of cases of COVID-19, and I think this study in particular was done in an earlier wave of COVID-19, in which we unfortunately saw patients with hematologic cancers have certainly much worse outcomes with COVID-19. Part of it, I think a large part of it was actually the fact that people can't respond, sort of develop a immune response to the vaccine. And unfortunately, when you're on treatment for CLL or lymphoma, a lot of times the treatment alone actually decreases your chances of having an immune response to COVID vaccine. So that is something to be aware of, despite the fact that the immune responses are not as good as the average person. We still do highly recommend getting COVID-19 vaccination as well as influenza in the fall. So right now I'm recommending that to patients. Um, and shingles is another one, as long as it's not a live vaccine. So, and finally, I just wanted to mention that it's a good idea just to optimize your general health to better tolerate treatment when needed. So that can be anything from cardiac to diabetic to anything. Okay, so I'm going to go on and talk about treatment of CLL. So the question is, why do we treat CLL? And this may seem obvious to a person first dealing with cancer, but you soon realize that the approach to treatment of CLL is quite different from other cancers. And why is that? So this particular type of cancer we cannot cure, even though we have a great treatment that's very, very effective. We cannot actually cure CLL, except with very drastic treatment like stem cell transplant. Um, and very importantly, starting treatment early does not impact survival. So in other words, you might think, well, the earliest we catch it and start treating it, the better. That is not the case in CLL. In fact, there are studies that show, patients that did start early did not survive longer than those that waited. And so what's recommended in CLL and in indolent lymphomas is that we monitor and not start on treatment until treatment is needed. And so this term was coined watch and wait, and this refers to being monitored and not embarking on treatment. Now, a very excellent nurse practitioner in our center published a paper called, well, actually, I don't know the name of the paper, but she coined the term monitor and move on as it uses terms that are more active, whereas watch and wait is more of a passive terminology. And her mantra is that we are going to monitor your blood work, we're going to monitor your lymph nodes, and best thing you can do for yourself is to try to live your life and move on and try not to worry about it as much. That's easier said than done in many cases, but that is our hope for you. And so in terms of what we actually do look for to start treatment, we want to see that we can actually improve your symptoms and complications related to CLL. So that may be large lymph nodes or large spleen that is causing you discomfort. Very low hemoglobin, platelets, or neutrophils, and that goes back to the problem in the bone marrow, where the bone marrow is crowded because of heavy deposits of those CLL cells. In less common circumstances, we may be looking at treating you if you have intractable night sweats, fevers, or weight loss. This is something called B symptoms, and we really have to be careful to make sure that we are convinced that it's due to CLL and not to something else, because there's certainly lots of other causes for these sort of vague symptoms. And then there's some patients that do get autoimmune anemia and low platelets. And if they don't respond to things like prednisone or steroids, then we may need to consider treatment of the CLL. Now, treatment of CLL has dramatically changed over the last 2 decades. So I started working as a hematologist in 2011. And so I was just on this precipice of the introduction of FCR, so chemoimmunotherapy, which was brand new, and everybody thought it was the best possible treatment for CLL in about 2010. And it was better than what they had before. But after that, starting in 2014, we had this explosion of new drugs that were approved for CLL. And to top it off, they were oral medications. So rather than having to come in to a cancer center to receive your treatment, you could just take these pills at home. And so I'm just going to go into detail about these treatments, and I'm going to focus on two groups. So this blob is a CLL cell, and it's just looking at some of the machinery and signaling that's going on in the CLL cell. And so don't get too worried about these letters. What I wanted to just show is that the first class of medication I'm going to talk about is BTK inhibitors, and that's just blocking one of these signaling proteins within the cell. And then the second one that I'm going to talk about is a combination of something called a BCL2 antagonist. There's currently only one drug called venetoclax, and that is actually blocking a signaling pathway as well. And so this is why we call these drugs targeted treatment, because they actually have a specific target that they hit within the cell and within the signaling pathways of the cell, and that's their weapon. They don't affect the other cells of the body because those cells are functioning normally, but these CLL cells have issues with their signaling, and that's what these drugs take advantage of. So, so yes, venetoclax, and then in combination, rituximab or obinutuzumab, which is blocking or sort of recognizing the surface marker CD20. Okay, so those are the two groups we're going to talk about. So starting with, I just don't want to go too much over time, but we'll start with Bruton's tyrosine kinase inhibitors. And I tried my best to not include survival curves in this, but it's pretty hard not to. I'll just for people that have never seen these graphs before, just spend a minute just to introduce this concept. So on the left, on the y-axis here, you see patients with progression-free survival. So that means they are alive and free of relapse. And so starting at 100% and going down. And then on the x-axis, you see months. Okay, so this is showing the results of a phase 3 clinical trial where they randomized patients that had newly diagnosed CLL that had never been treated before but needed treatment. They randomized them to receive either ibrutinib, which is a BTK inhibitor, the very first novel agent that was approved, versus chlorambucil, which is a chemotherapy drug that had been used for decades before. And what you see, the ibrutinib arm is in orange and the chlorambucil arm is in blue, and you see a huge difference between the ibrutinib treated patients. They remained free of relapse or death much longer than the patients on chlorambucil. So we can say that this ibrutinib drug was significantly more effective at treating the CLL. And so this and other studies have completely revolutionized the treatment of CLL, because I would venture to say every single clinical trial that has been conducted comparing chemotherapy to novel agent therapy has shown the very same thing. And that's true of even FCR. So, and this interesting paper that was just published this year looked at kind of a large number of patients that had been treated with ibrutinib as first-line treatment, and they actually showed that there's, compared to the age-matched general population, no difference in their overall survival, which is remarkable, because if you look at the people that previously had been treated with chemotherapy, there was a difference that they did not survive as long as their age-matched peers. And so this is, dramatically better. And even better than that, we have seen new second generation BTK inhibitors that improve upon both the effectiveness and the toxicity of ibrutinib. And so this clinical trial is actually looking at people that have relapsed. So they had a prior treatment, and then they randomized them to receive either ibrutinib, which is the drug we just talked about, or zanubrutinib, which is a newer BTK inhibitor. And they saw that again, this is a progression-free survival curve. So they saw that the patients in green who had zanubrutinib um, did better, significantly better than the patients that received ibrutinib, which is remarkable. Um, and one thing that I hadn't really introduced yet, but is nicely shown in this graph, is that even patients that have TP53 mutation, and not pictured here, but people that have unmutated IGHV uh, also do quite well with these drugs, with these novel agents. So zanubrutinib treated patients with these mutations. Look at this. Their progression-free survival median is 59% compared to 65% without, sorry, with the whole group. Um, that is remarkably similar. And so, that is also one of the advantages of these novel agents, that the high-risk patients can get almost as much benefit from these drugs, whereas chemotherapy, just didn't work for high-risk CLL. Now, side effects do happen. They are overall less than with chemotherapy. Now, but they're quite different. Now, kind of lower grade or lower seriousness side effects include diarrhea, rashes, fatigue, um, aching muscles and aching joints, and even swollen joints. And some of them can cause headaches. In particular, acalabrutinib tends to cause headache. And then some adverse events that we're particularly concerned about are bleeding, and these drugs need to be stopped prior to surgery, but can also cause, serious bleeding, high blood pressure, atrial fibrillation, and even more serious arrhythmias, and also infection. So they are not free of issues. Um, and so just a little bit of a summary, the BTKIs, that's the Bruton tyrosine kinase inhibitors, produce longer remissions than chemoimmunotherapy with less toxicity in both the relapsed and the frontline setting. And they have excellent responses, or they produce excellent responses in patients with high-risk CLL. Um, Generally speaking, they are used as an indefinite treatment. So you start taking these pills and you don't stop. Even when your doctor tells you that the CLL is looking great and they can't see any sign of active CLL and your lymph nodes have shrunk and your spleen has shrunk, you still keep taking it. And so that is a little bit problematic because some of these side effects are bothersome. It can result in drug resistance. Um, and it is a cost to the system, or if you're in a private healthcare system, it can cost you personally. And then just final point that the second generation drugs have improved toxicity profiles significantly. So I'm going to move on to BCL2 inhibitors. So again, the only one approved right now is venetoclax. And so I don't have a lot of slides on this one, but I do want to say that it is extremely effective. And so this trial is called CLL14, and it is looking at patients that had no previous treatment prior, and they randomized 50-50 to patients getting venetoclax plus obinutuzumab. So that's the novel agent plus a CD20 antibody, which is how this drug is used, generally speaking, with a schedule of the antibody being monthly times 6 months, and then overlapping with daily venetoclax pills for 12 months. So a total of 12 months, and then stopping. So this is different from the previous schedule where you took the pill indefinitely. Okay, so on this trial, the patients either received venetoclax plus obinutuzumab or they received chlorambucil plus obinutuzumab. So you remember chlorambucil from the first trial I showed you, where these were chemotherapy pills that have been used for decades. At one point, that was our standard of care. So look at these survival curves. So again, we're seeing that the novel agent, which is pictured in blue, these patients are in remission and alive a lot longer than the patients that had received the standard chlorambucil obinutuzumab. So again, novel agents win over chemoimmunotherapy, and that has been showed in multiple trials with this drug, but I just showed the one. Again, this drug has side effects, but they are quite different from those of the BTK inhibitors. So we actually don't see any issue with bleeding, with cardiac, nothing like that. So this is quite different. So we do, though, see something called tumor lysis syndrome. So that is basically a problem with the electrolytes within the cells that then escape into the blood when the drug is started, because it's killing those cancer cells. It can also result in gout and kidney issues because of uric acid in the blood. And so the treatment for that is giving fluid, giving a drug called allopurinol, which prevents tumor lysis, slowly ramping up the drug over the course of 5 weeks, and frequent lab monitoring of electrolytes throughout that period. So it seems simple, but it can actually cause a really great deal of issues, because at the beginning we were all scared that our patients would have to, be admitted to hospital for these really frequent lab tests. And as we became more and more comfortable with the drug, that is really not the case anymore. But certainly it does cause issue for the patient, because of course, the patients have to come and do all this lab monitoring and drive to the cancer center every day or every, twice a week, and drink the fluid. And so, it is not without its issues. But it isn't dangerous as long as we follow the protocol. Other things are neutropenia, so low neutrophils. Usually those don't result in infection, but that can be an issue as well. Yeah, so generally speaking, venetoclax tends to be more easily tolerated than BTKIs, I would say. I guess I did not include in that slide here, sorry, I'm just backing up, the side effects of the intravenous antibodies, which includes kind of allergic reactions to the antibodies. And, you have to take some allergy medication and Tylenol to prevent those reactions. Okay. Now, I wanted to also introduce to you, this is a combination treatment that it takes advantage of using 2 different types of novel agents and combining them together. So this trial was called the GLOW trial, where they randomized patients to receive the standard chlorambucil obinutuzumab or the combination of 2 novel agents, ibrutinib and venetoclax. And again, we see that there's a significant improvement in remission duration and survival with the novel agents. And very important to know that this combination was only given for 1 year. So, you sort of take away that indefinite time course of the ibrutinib, and it still gives patients a great response. And this slide just goes through and describes a bit about how this is advantageous. So what I didn't mention about ibrutinib is that actually mobilizes CLL cells out of their um, environments of lymph nodes and other protective niches into the bloodstream. And then with venetoclax, as it accelerates cell death, it gives the drug better access to these CLL cells, and it's able to then kill them. So that combination is approved by Health Canada, but sitting with provinces to decide whether they are going to approve it. Interestingly, the FDA did not elect to approve that combination, which is quite unusual. So just a quick summary, the venetoclax BCL2 inhibitor in combination with CD20 antibody in a fixed duration of 1 year produces superior remission rate to chemo, even in high-risk CLL. Again, I didn't show that particular population, but know that they are also responding very well. And we're seeing that it can produce a high rate of clearing of the CLL cells from the blood and the bone marrow. And so investigators are starting to talk about this minimal residual disease concept where they're, having to look with extreme detailed studies to find the remaining CLL cells because this drug does such a good job of clearing them. There's, yes, a risk of tumor lysis during initiation. Because it's fixed duration, you don't get as much drug resistance. So that is a benefit. And then it's allowing the combination with other novel agents. But one of the questions that comes up with this combination treatment is what treatment then would you be able to use after you relapse? And that's caused some investigators and patients to stop and think a bit more. So I just wanted to run through what's our current frontline treatment options for CLL, SLL in Alberta. And it's probably quite similar in other provinces. So if you don't have deletion 17p or TP53 mutation, and you have unmutated IGHV, you can actually choose between venetoclax obinutuzumab or BTKI. So those two options are open. If you don't have deletion 17p, but you have mutated, so the better prognostic type, our guidelines still state that you can receive chemo. However, I just want to point out that many of us don't offer the chemo or have a discussion with the patient and likely there's a preference not to have chemo. But the venetoclax obinutuzumab is an open possibility. And then if there is a deletion 17p, again, you can have the choice of either of these two options of novel agents. So I don't have a lot of time. I think I'm going to skip. These are just pros and cons of each type. And I just want to show my kind of last two slides. This one is talking about treatment sequencing. And I really like this concept because this is sort of how I talk to patients about which one to choose if you do have a choice between the two. So if you're on a BTK inhibitor, you're on it indefinitely, and then maybe 7-8 years down the road you relapse and you're getting your venetoclax, but then you don't get any break. from treatment. Whereas if you do start with the BCL2 inhibitor, you get a break after a year, and then you start your next line of treatment after that. So you do have this nice holiday of several years. Even in option C, where you take the venetoclax for a year and then you take a break, you can repeat again the same treatment. And then down the road, you still have the option of BTK inhibitors and so on. So that's something to think about. It's not that we have all the answers, and sometimes people will have been started on BTK inhibitors when they became available and didn't have any other choice. It's not wrong. I'm just pointing out that if you have the option, maybe it's something to think about. And then this last slide is just saying that this study looked at patient priorities just out of interest, and kind of did I forget how they termed it, but some sort of choice experiment. And it turned out that the priorities for patients tended to be more about possible occurrence of infections, talking about treatment duration, the possibility of organ damage, the remission duration, and then diarrhea was the last most important. So last slide, I'm sorry I went a bit over the time I wanted, but this is the last one that just looks at future treatments. So we do have some up and coming treatments, mostly in clinical trials. This pirtobrutinib is a drug that is available in the US and is just going through the approval process in Canada, but we can access it on a compassionate program. It is a non-covalent BTKI, so even if you have resistance to the covalent, the ones that I talked about, the standard BTKIs, you could still respond to this drug. Quite a few people do. There's new BCL2 inhibitors coming through in clinical trials. We've just opened one today, a clinical trial using that new drug. And as I mentioned, there's novel agent combinations. So we're seeing different combinations: venetoclax, acalabrutinib, obinutuzumab, zanubrutinib. So those are coming down the pipeline. We also have currently in Edmonton a study on BTK degrader, and there's a few versions of this, but this again is a sort of a different version of a BTK inhibitor that gets around the resistance. And then finally, there's two options that are cellular therapy, including CAR T cell therapy that are, I think CAR T is actually approved in the US, but it's still experimental only in Canada. So just a final summary. Treatment outcomes in CLL have massively improved with novel agents. Patients have options and can participate in choosing treatment depending on different factors in their life, and that is quite nice. The role of combination novel agent therapy is unclear, and we do have some future investigational drugs coming down the pipeline. And so I'm just going to open it up for questions. Sorry that I went a little bit over time.
Oh, thank you, Dr. Peters, for sharing your expertise and insight. That was a great presentation. As noted on the presentation, it's now time for our Q&A period. So if you haven't done so already, be sure to pop it in the Q&A box in the Zoom webinar. As mentioned earlier, just because we do have a large number of participants and very limited time, we may not get to all the questions. And also just a reminder that Dr. Peters cannot answer any specific questions about a person's health history or status. All right, so we'll get into the question. The first one I have here for you, Dr. Peters. What doses of vitamin D were used in the study, and what would you recommend?
That's a great question, and I don't think I actually know off the top of my head, but what I would recommend is between 1,000 units and 2,000 units. That's pretty standard, and going above that, I think would risk toxicity, but 1 to 2,000 would be great per day.
Awesome. And the next question I have for you, we have someone asking in 2020 they were treated for CLL. It
Mhm.
was an IV protocol as opposed to an oral pill. You'd mentioned that the oral type was the case since 2014, and they're curious if one is better than the other or why one would be an option over the other.
So an intravenous treatment. I wonder if that would have been, well, maybe it could have been chemotherapy. And so even, if you had a mutated CLL type and you were young and fit, quote unquote, like good organ function and doing well, the option was still available even today to receive things like FCR, so that's fludarabine, cyclophosphamide, rituximab, that's chemotherapy, or bendamustine, rituximab. So I wonder if that was, I suspect that's probably what it was. And it's not wrong. And it was good treatment. It still is good treatment. The reason that we've turned away from chemotherapy is generally because of the higher rate of infections during the treatment. And after the treatment, there is a higher rate of secondary leukemias, not CLL, but actually developing a different type of leukemia from the treatment. So we don't see that. I'm not saying zero, but we see a much lower risk of that with novel agents.
Thank you. Next question I have for you. Is there any material difference between acalabrutinib and zanubrutinib?
That's a really good question. So they've never compared them head to head in a clinical trial, and I don't think we're going to see that happen. Um, and so basically what I talk about with my patients is that with zanubrutinib, you have to take it twice a day. So it's one pill twice a day. Whereas with zanubrutinib, it's 4 capsules, and you can either take them all at once or 2 capsules twice a day. So if you have a bit of a difficulty with swallowing pills, it might be better to do the acalabrutinib just because there's fewer pills. Some people have trouble remembering, so sometimes once a day is better. So maybe zanubrutinib would be better. Um, and then the only other thing is the acalabrutinib can cause headache. So if you really kind of don't like that risk or you already have migraines, then you might not want to do acalabrutinib.
It sounds like it's really dependent on the individual.
Yeah, yeah, because they're both available.
Hmm. And the next question was the ibrutinib and venetoclax combo for first line or relapse? And then second to that, can it be given to patients with CLL with multiple mutations?
Yep, it's in first line. So the study was in patients that had not had prior treatment, and that's what it is approved for by Health Canada. So I don't think we'd be able to do it in a patient that's relapsed, but yeah, I think it's actually really excellent treatment for people with mutations and sort of high risk patients.
Okay, right. And then can CLL go in remission with the TP53 gene?
Yes, absolutely. Yeah. And much more so now than it used to with chemo. Chemo was often only temporarily effective, but with our new treatments, you can go into remission for several years and then respond well to the next type of novel agent.
We have time for one more question here. So let's see. What about the 6q deletion and IgHV non-mutated results of Neovax vaccine,
Uh,
Dana-Farber?
I'm not sure about that. So the vaccine for COVID or vaccine for like vaccine against CLL, maybe?
There was no
Okay.
expansion on that, unfortunately.
Okay. Sorry about that.
Um,
I don't know much about that. But if there is such a thing being developed, that's super exciting. And the was it 6q deletion? That must be a very rare
Yeah.
type. Yeah, because we used to do a full panel of mutation analysis with fish, and the ones we tested were 13q, 11q, 12p, and 17p. Six, yeah, I think I've heard it might be picked up if you do a karyotype, like
Mhm.
looking at all the chromosomes,
Mhm.
but it's not one of the standard ones. So I can't
Okay.
really comment on the prognosis of that type.
Well, thank you so much for your time today,
You're
and
welcome. My pleasure.
time to answer some of the questions. If you wouldn't mind popping up the slide deck, I'm just gonna,
Mhm.
I just have a couple slides here. Um, Before we sign off today, I would like to remind everyone of our upcoming conferences this week. So we have the CML chronic myeloid leukemia. If you wouldn't mind just swapping the view for
Oh,
me.
sure.
So that one is happening this afternoon at 3 p.m. Eastern Standard Time. And then
Mm.
we have our ALL acute lymphoblastic presentation tomorrow at 3 p.m. Eastern Standard Time. Sorry, Dr. Peters, the slide doesn't seem to be up on the screen.
I'm trying
Oh,
to
no worries.
fix it.
Okay. Um,
Sorry about this.
oh, that's okay. And then on November 8th, which is the Friday, we have how to actively participate in your cancer care, which starts at 1 p.m. Eastern Standard Time. If you haven't already registered, you can feel free to do so on our website. Next slide, please. We would also like to take a moment to thank our sponsors, AbbVie, Astellas, AstraZeneca, Bristol Myers Squibb, Jazz Pharmaceuticals, Johnson & Johnson, and Novartis for their support in making these conferences possible. Next slide, please. And please remember that we are here to help you. You can reach out to us by email. You can visit our website, bloodcancers.ca, or by calling us toll free. Please note that a short survey will be sent to all participants today after our presentation. If you could take a moment to respond, it really helps us with planning future events. And then just one more slide. Again, a big thank you for being here with us today, and please take good care of yourself. Bye for now.